Welcome, everyone. I'm glad you're here today. We're about to dive into an important topic, diuretics. This is the first slide of our presentation, and I want to give you a quick overview. We'll explore what diuretics are, how they work, and their clinical uses. So let's get started and learn more about these powerful medications that play a key role in managing various conditions. Let's talk about diuretics. A diuretic is an agent that increases urine volume, helping the body get rid of excess fluid. Now, a natriuretic specifically promotes the excretion of sodium through the kidneys. This is important because sodium balance plays a big role in regulating blood pressure and fluid levels. Then, we have aquaretics, which increase the excretion of solute-free water, essentially helping the body lose water without losing much salt. It's interesting to note that most natriuretics also tend to increase water excretion, so they're often classified as diuretics as well. Understanding these distinctions helps us see how different agents can influence fluid and electrolyte balance, which is a core aspect of managing conditions like hypertension and edema. Remember, these concepts tie into the overall theme of how we manipulate fluid and electrolyte homeostasis to improve patient outcomes. Let's talk about carbonic anhydrase inhibitors. Carbonic anhydrase, or Ca, is mainly found in the epithelial cells of the proximal convoluted tubule, or PCT. Its role is to catalyze the dehydration of H2CO3 into CO2 at the luminal membrane, and then to assist in rehydrating CO2 back into H2CO3 inside the cell. This process is crucial for the reabsorption of bicarbonate and sodium. When we use inhibitors to block Ca, it disrupts this process. Specifically, it blunts the reabsorption of sodium bicarbonate, or NaHCO3, which leads to increased urine production or diuresis. Some common drugs that act as Ca inhibitors include acetazolamide, duclorfunomide, mufazolamide, dazolamide, and brunzolamide. These medications are useful in various clinical scenarios, especially where reducing fluid reabsorption is beneficial. Understanding this mechanism helps us see how these drugs contribute to their therapeutic effects, tying into the broader picture of managing fluid balance and certain conditions like glaucoma or altitude sickness. Now, let's discuss the pharmacokinetics of carbonic anhydrase inhibitors. These drugs are well absorbed after oral administration, which makes them convenient for patients. Once absorbed, they are excreted primarily through secretion in the proximal tubule, specifically in the S2 segment. This is a key point because it influences how we dose the medication, especially in patients with renal impairment. Since the excretion depends on renal function, if a patient has renal insufficiency, we need to reduce the dose to prevent accumulation and potential toxicity. Additionally, it's important to remember that for these drugs, renal excretion involves both renal clearance and metabolism. The notation on the slide shows that R indicates renal excretion, and M indicates that metabolism is required for excretion. This highlights how both processes are involved, and it emphasizes the need to consider renal function when managing therapy with carbonic anhydrase inhibitors. This overall understanding helps us optimize treatment while minimizing adverse effects, especially in vulnerable patient populations. Now, let's delve into the pharmacodynamics of carbonic anhydrase inhibitors. These drugs profoundly depress bicarbonate reabsorption in the proximal convoluted tubule, or PCT, by about 85%. This results in significant bicarbonate losses and can lead to a hyperchloremic metabolic acidosis. Essentially, you're losing bicarbonate, which is crucial for maintaining acid-base balance, and this loss causes a shift in chloride levels. Interestingly, these inhibitors block roughly 45% of the bicarbonate reabsorption across the entire kidney. Keep in mind, there are other sites in the nephron that can reabsorb bicarbonate, so this isn't the complete picture. Now, because the reduction in bicarbonate in the glomerular filtrate leads to less bicarbonate being reabsorbed, the body compensates by reabsorbing more sodium chloride elsewhere in the nephron. This compensatory mechanism actually decreases the diuretic effectiveness of drugs like acetazolamide over several days. Lastly, it's important to note that these inhibitors are mainly used outside of the kidney, particularly in the eye and brain, where they inhibit carbonic anhydrase-dependent transport of bicarbonate and fluids. This highlights their broader therapeutic applications beyond diuresis. Now, let's talk about some clinical applications of carbonic anhydrase inhibitors. First, in the case of glaucoma, these drugs work by reducing the production of aqueous humor, which is the fluid inside the eye. By doing so, they help lower intraocular pressure, which is crucial in managing glaucoma and preventing vision loss. Next, they have a role in urinary alkalinization. Uric acid and cysteine, which are substances that can form stones, are relatively insoluble in acidic urine. When we use CA inhibitors to make the urine more alkaline, it helps dissolve or prevent the formation of these stones. So, in essence, these drugs can be quite useful beyond their primary effects, addressing issues related to fluid balance and stone formation. Understanding these applications ties back to the overall theme of how targeting enzyme activity can have widespread therapeutic benefits. Now, let's look at the clinical application of carbonic anhydrase inhibitors, specifically in the context of metabolic alkalosis. Typically, metabolic alkalosis is managed by correcting underlying issues such as abnormalities in total body potassium, intravascular volume, or mineralocorticoid levels. But there are specific scenarios where acetazolamide can be especially useful. For example, in patients with severe heart failure who are on diuretics, excess diuretic use can lead to alkalosis. In these cases, acetazolamide not only helps correct the alkalosis, but also promotes a small amount of additional diuresis, which can aid in correcting volume overload. Additionally, acetazolamide can be used to rapidly correct metabolic alkalosis that sometimes occurs after treating respiratory acidosis. So, in summary, while managing alkalosis often involves addressing volume and electrolyte imbalances, acetazolamide provides a targeted approach when diuretics or post-respiratory correction scenarios are involved. Let's take a look at the clinical application of carbonic anhydrase inhibitors, specifically in the context of acute mountain sickness. When people rapidly ascend above 3,000 meters, they often experience symptoms like weakness, dizziness, insomnia, headache, and nausea. These are typical early signs that the body is struggling to adapt to the low oxygen levels at high altitude. In more severe cases, this can escalate to dangerous conditions such as pulmonary or cerebral edema, which can be life-threatening if not addressed promptly. That's why understanding these symptoms and early intervention is crucial. Interestingly, the mild metabolic acidosis caused by these inhibitors, affecting both the central nervous system and cerebrospinal fluid, can actually be beneficial. For instance, this acidosis helps in the treatment of sleep apnea by reducing the tendency for airway collapse during sleep. So overall, carbonic anhydrase inhibitors play a significant role not only in managing altitude sickness, but also in other conditions like sleep apnea, highlighting their versatile clinical applications. Now, moving on to some of the other clinical applications of carbonic anhydrase inhibitors. These drugs are actually quite versatile. For example, they have been used as adjuvants in the treatment of epilepsy, helping to reduce seizure frequency in some cases. They also play a role in managing certain types of hypokalemic periodic paralysis, which is a condition characterized by episodes of muscle weakness linked to low potassium levels. Another important use is in patients with cerebrospinal fluid, or CSF, leakage. By decreasing the rate at which CSF is produced, carbonic anhydrase inhibitors can help slow down the leakage and reduce intracranial pressure, which is often crucial in these cases. Lastly, they are useful in managing severe hyperphosphatemia. During such episodes, they increase urinary phosphate excretion, helping to lower serum phosphate levels more effectively. So, as we see, these inhibitors have a broad range of applications beyond their primary uses, connecting back to the overall theme of how they influence fluid and electrolyte balance in various clinical scenarios. Now, let's talk about some of the toxicity concerns associated with carbonic anhydrase inhibitors. One of the key issues is hyperchloremic metabolic acidosis, which occurs because these drugs can cause a buildup of chloride and acid in the blood. This shift can affect the body's acid-base balance. Another important point is the formation of renal stones. Because these inhibitors can lead to phosphaturia and hypercalciuria, there's increased calcium and phosphate in the urine, which can promote kidney stone formation. Additionally, the chronic use of these drugs may reduce the renal excretion of solubilizing factors like citrate, further increasing the risk of stones. Moving on, there's also the issue of renal potassium wasting. Since these drugs increase sodium delivery to the collecting tubules along with bicarbonate, potassium can be wasted, leading to hypokalemia. Fortunately, this effect can often be mitigated by giving potassium chloride or a potassium-sparing diuretic at the same time. Understanding these toxicity points is crucial because they highlight the importance of careful monitoring and management when using carbonic anhydrase inhibitors. Now, let's talk about some other toxicities associated with carbonic anhydrase inhibitors. When taken in large doses, they can cause drowsiness and paresthesias, which are abnormal sensations like tingling or numbness. It's also important to remember that these drugs tend to accumulate in patients with renal failure, and this buildup can lead to nervous system toxicity, so caution is definitely needed in those cases. Additionally, hypersensitivity reactions can occur, including fever, rashes, and even more serious issues like bone marrow suppression and interstitial nephritis. Lastly, a key contraindication to keep in mind is in patients with cirrhosis. In such cases, these drugs are generally avoided because of potential complications. Overall, while they can be effective, understanding these toxicities helps us use them safely and recognize when they might not be appropriate. Loop diuretics are a powerful class of drugs that primarily work by inhibiting NaCl reabsorption in the thick ascending limb of the loop of Henle. This mechanism makes them some of the most effective diuretics we have today. When they block this reabsorption process, it leads to a significant increase in the excretion of sodium, chloride, and water, which is especially useful in cases of edema and heart failure. The most common agents in this class include furosemide, ethacrynic acid, bumetanide, and torsemide. Each of these has slightly different properties, but they all share this key mechanism of action, making them the go-to options when potent diuresis is needed. So, understanding how they work helps us appreciate why they're considered the most efficacious diuretics available and how they fit into broader treatment strategies. Let's dive a bit deeper into the pharmacodynamics of loop diuretics. When these drugs act, they actually induce the expression of enzymes called cyclooxygenases, specifically COX-2. Now, COX-2 plays a key role in producing prostaglandins, which are important mediators in the body. One particular prostaglandin, PGE2, is especially interesting because it inhibits salt transport in the thick ascending limb of the loop of Henle. This means that PGE2 helps enhance the diuretic effect by reducing salt reabsorption. It's also important to note that nonsteroidal anti-inflammatory drugs, like indomethacin, can interfere with this process. They block prostaglandin synthesis, which can blunt the effects of loop diuretics, especially in patients with conditions like nephrotic syndrome or hepatic cirrhosis. Finally, loop diuretics don't just act on the kidneys, they also affect blood vessels. By promoting prostaglandin production, they can increase blood flow, which can have systemic effects, including vasodilation. This vascular action adds another layer to how these drugs influence overall fluid and blood pressure regulation. Now, let's dive into the continued clinical applications of loop diuretics. First, in cases of hyperkalemia, particularly mild hyperkalemia, or after we've managed severe hyperkalemia with other measures, loop diuretics can be very helpful. They work by increasing the excretion of potassium through the urine, which helps us bring potassium levels back to a safer range. Next, regarding acute renal failure, loop diuretics can be quite beneficial here as well. They help increase the rate of urine flow, which not only assists in removing excess fluids, but also promotes potassium excretion. This dual action is especially useful when we're trying to manage complications associated with acute renal failure. Overall, these points highlight how loop diuretics are valuable tools in managing electrolyte imbalances and renal function, fitting into the larger picture of maintaining fluid and electrolyte balance in various clinical scenarios. Now, let's talk about the clinical applications of loop diuretics, specifically in cases of anion overdose. These medications are particularly useful when dealing with toxic ingestions of substances like bromide, fluoride, and iodide. The reason is that these ions are reabsorbed in the thick ascending limb of the loop of Henle, so loop diuretics can help enhance their excretion. Another important use of loop diuretics is in treating acute pulmonary edema, which is often caused by heart failure or other cardiac issues. They help reduce the fluid overload in the lungs, easing breathing and improving oxygenation. Beyond pulmonary edema, they're also valuable in managing other edematous conditions, such as congestive heart failure or severe edema from various causes. Lastly, they are key in cases of acute hypercalcemia. Since loop diuretics increase calcium excretion, they can help lower elevated calcium levels quickly and effectively. So, in summary, while their primary use is for edema and hypercalcemia, their role in managing certain toxic overdoses highlights their versatility and importance in clinical practice. Now, let's discuss the toxicity associated with loop diuretics. One key point to remember is that these drugs can cause hypokalemic metabolic alkalosis, which results from the loss of potassium and hydrogen ions. This imbalance can lead to muscle weakness and other complications if not monitored carefully. Additionally, loop diuretics are known to be ototoxic, but it's important to note that this effect is dose-related and usually reversible once the medication is adjusted or discontinued. So, patients might experience temporary hearing issues at higher doses. Another concern is hyperuricemia, which can increase the risk of gout. Loss of magnesium or hypomagnesemia is also common and can predispose patients to arrhythmias. We should also be aware of allergic reactions, such as skin rashes, eosinophilia, or even interstitial nephritis, which, while less common, can be serious. Severe dehydration and hyponatremia are significant risks, especially if diuretics are overused or not properly managed. These can lead to dizziness, confusion, or even more severe complications. Lastly, in volume-depleted patients, you might see mild hypocalcemia alongside secondary hyperparathyroidism. Interestingly, in some cases, hypercalcemia can also occur, further complicating the picture. Understanding these toxicities helps us balance the benefits of loop diuretics with their potential risks, ensuring we use them safely within the broader context of managing conditions like edema and hypertension. Now, let's talk about some important considerations with loop diuretics. First, regarding contraindications, it's worth noting that drugs like furosemide, bumetanide, and torsemide can sometimes cause allergic reactions in patients who are sensitive to other sulfonamides. However, this cross-reactivity is actually quite rare. Another key point is that overusing any diuretic can be risky, especially in certain patient populations. For example, in those with hepatic cirrhosis, borderline renal failure, or heart failure, excessive diuretic use can lead to serious complications. So, the take-home message here is to be cautious and tailored with diuretic therapy, considering both potential allergies and the delicate balance needed in these vulnerable conditions. This helps us ensure safe and effective treatment while avoiding unintended harm. Now, let's take a closer look at thiazide diuretics. These drugs, including bendraflumethiazide, chlorothiazide, chlorothalidone, and hydrochlorothiazide, among others, are commonly used in clinical practice. They are part of a broader class that share similar mechanisms, but there are some important differences to note. All of these thiazides can be taken orally, which makes them convenient for long-term management. However, their metabolism can vary, so understanding these differences can help us optimize their use for individual patients. Another key point is how all these drugs are handled by the body. They are secreted in the proximal tubule of the kidney via the organic acid secretory system. This is significant because it influences not only their effectiveness, but also their interactions with other substances. Specifically, they compete with uric acid for secretion through this system. This competition can lead to increased uric acid levels, which is important to keep in mind, especially for patients prone to gout or hyperuricemia. So, in summary, while thiazide diuretics are a versatile and widely used class, their differences in metabolism and their interaction with uric acid secretion are crucial considerations in their clinical application. Now, let's take a closer look at thiazide diuretics and their pharmacokinetics. When we talk about pharmacokinetics, we're referring to how the drug is absorbed, distributed, metabolized, and finally eliminated from the body. For thiazides, the key points to remember are their routes of excretion. They are primarily eliminated through the kidneys, which is denoted as R for renal. Additionally, some metabolism occurs. Although it's minimal for most thiazides, it's still a factor to consider. This is represented as M for metabolism. Lastly, we have biliary excretion, abbreviated as B, which means some of these drugs are excreted via the bile into the gastrointestinal tract. Understanding these routes helps us grasp how the drug levels are maintained and how they might be affected in cases of renal or liver impairment. This is crucial as it ties into the overall theme of pharmacokinetics and optimizing therapy for our patients. Now, let's continue with the pharmacodynamics of thiazide diuretics. These drugs work by inhibiting the reabsorption of sodium chloride, or NaCl, from the luminal side of epithelial cells in the distal convoluted tubule. They do this specifically by blocking the Na+/Cl- transporter, which is essential for sodium and chloride reabsorption in this part of the nephron. An important point to remember is that their action partly depends on the production of renal prostaglandins, or PGs. These prostaglandins help modulate the effect of the diuretics, influencing how effective they are in promoting sodium and water excretion. Understanding this mechanism is key because it explains how thiazides reduce blood volume and blood pressure, which is central to their role in managing hypertension and edema. So, their effect isn't just about blocking transporters. It's also intertwined with the body's prostaglandin pathways, highlighting the complexity of their pharmacodynamics. Now, let's take a closer look at the clinical applications of thiazide diuretics. The main reasons we prescribe these medications are quite significant. First, they are widely used in the management of hypertension, helping to lower blood pressure effectively. Next, they play a role in treating heart failure by reducing fluid overload and alleviating symptoms. They are also beneficial in cases of nephrolithoases caused by idiopathic hypocalciuria, which is a condition where too much calcium is excreted in the urine, leading to kidney stones. Lastly, thiazide diuretics are used in nephrogenic diabetes insipidus, a disorder where the kidneys can't concentrate urine properly. Recognizing these key applications helps us understand how versatile and essential these drugs are in various clinical scenarios. Now, let's discuss some of the toxicities associated with thiazide diuretics. One of the main concerns is hypokalemic metabolic alkalosis, which occurs due to potassium loss, and this can also lead to hyperuricemia, increasing the risk of gout. Additionally, these diuretics can impair carbohydrate tolerance, resulting in hyperglycemia, so they may affect blood sugar levels. Another important point is that they can cause hyperlipidemia, specifically by increasing total serum cholesterol and LDLs. These side effects highlight the need to monitor patients closely when they're on thiazide diuretics, especially since they can impact cardiovascular risk factors. This connects to the overall theme of balancing therapeutic benefits with potential adverse effects. Now, let's continue with thiazide diuretics and their potential toxicity. One of the key issues to be aware of is hyponatremia. This occurs mainly because thiazides can cause hypovolemia, which then triggers an increase in antidiuretic hormone, or ADH, leading to water retention and dilutional low sodium levels. It's important to recognize that this can be dangerous, especially in elderly patients or those with other risk factors. Next, although rare, allergic reactions can occur. Some patients might experience photosensitivity, meaning their skin becomes more sensitive to sunlight, or they might develop generalized dermatitis. Even more rarely, severe reactions like hemolytic anemia, thrombocytopenia, or acute necrotizing pancreatitis have been reported. Patients might also experience side effects like weakness, fatigue, or paresthesia, those abnormal sensations, and in men, impotence can sometimes be an issue. It's crucial to remember that excessive use of thiazides can be particularly risky in patients with hepatic cirrhosis, borderline renal failure, or heart failure, because their fluid and electrolyte balance is more fragile. So, while these medications are effective, careful monitoring and understanding of these potential toxicities are essential for safe therapy. Let's talk about potassium-sparing diuretics. These include drugs like spironolactone, eplerenone, amiloride, and triamterene. Their main role is to prevent potassium secretion in the kidneys by antagonizing the effects of aldosterone in the collecting tubules. Essentially, they block the action of aldosterone, which normally promotes sodium reabsorption and potassium excretion. They can do this either by directly blocking mineralocorticoid receptors or by inhibiting sodium influx through specific ion channels in the luminal membrane of the tubules. Now, there's also nesiretide, which is only available for intravenous use. It works a bit differently. It increases the glomerular filtration rate, or GFR, and reduces sodium reabsorption in both the proximal and collecting tubules. This helps promote diuresis and natriuresis. It's important to note that the effectiveness of aldosterone antagonists depends on renal prostaglandin production. Prostaglandins help modulate renal blood flow and sodium transport, so their presence can influence how well these drugs work. Overall, these agents are valuable in managing conditions like heart failure and hypertension, especially when balancing fluid and potassium levels is critical. Now, let's continue with potassium-sparing diuretics, focusing on their pharmacokinetics. When we talk about pharmacokinetics, we're looking at how these drugs are processed in the body. M stands for metabolism, which refers to how the body breaks down these medications, while R indicates renal excretion, meaning how they are eliminated through the kidneys. Understanding these aspects is crucial because it helps us determine the dosing, potential interactions, and side effects. For example, since these drugs are primarily excreted by the kidneys, impaired renal function can lead to accumulation and increased risk of hyperkalemia. So, in essence, their pharmacokinetics highlight the importance of monitoring kidney function during therapy and adjusting doses accordingly. This ensures we maximize therapeutic benefits while minimizing adverse effects, tying back to our overall goal of safe and effective diuretic use. Potassium-sparing diuretics continue to be an important part of our therapeutic arsenal, especially in specific clinical situations. They are most useful in conditions characterized by mineralocorticoid excess or hyperaldosteronism. This can happen in cases where there's primary hypersecretion, like in Conn's syndrome or ectopic adrenocorticotropic hormone production, or in secondary hyperaldosteronism, which often occurs due to conditions that reduce effective blood volume. For example, heart failure, hepatic cirrhosis, and nephrotic syndrome can all lead to increased aldosterone levels as the body tries to compensate for low blood volume. It's also important to remember that other diuretics, such as thiazides or loop agents, can sometimes cause or worsen volume contraction. When this happens, the body responds by increasing aldosterone secretion, leading to secondary hyperaldosteronism. Understanding these mechanisms helps us appreciate why potassium-sparing diuretics are especially beneficial in these scenarios. They can help counteract the effects of aldosterone excess and prevent further potassium loss. This highlights how these agents fit into the overall management of conditions related to fluid and electrolyte imbalances. Now, let's look at the clinical applications of potassium-sparing diuretics. When there's increased mineralocorticoid secretion and a high delivery of sodium to the distal parts of the nephron, the kidneys tend to waste potassium. In this situation, potassium-sparing diuretics can be very useful because they help blunt the potassium secretory response, helping to maintain potassium levels. Additionally, low doses of eplerenone, one of these diuretics, can interfere with some of the harmful effects of aldosterone, such as fibrosis and inflammation. This is particularly important because it can slow down the progression of albuminuria in diabetic patients, which is a key factor in diabetic kidney disease. But perhaps even more significant is the role of eplerenone in cardiovascular health. After a myocardial infarction, eplerenone has been shown to reduce myocardial perfusion defects, which can help improve heart function and outcomes. So, in essence, potassium-sparing diuretics like eplerenone not only help manage fluid and electrolyte balance, but also have protective effects on the heart and kidneys, tying into the broader theme of cardiovascular and renal health management. Now, let's continue with potassium-sparing diuretics and discuss some potential toxicities associated with their use. One of the main concerns is hyperkalemia, which is an elevated level of potassium in the blood. This risk is greatly increased if the patient has renal disease or is taking drugs that decrease or inhibit renin, such as beta blockers, NSAIDs, or aliskiren. Similarly, drugs that block angiotensin II activity, like ACE inhibitors and angiotensin receptor blockers, can also heighten this risk. Another important toxicity to be aware of is hyperchloremic metabolic acidosis, which can occur due to the disturbance in electrolyte balance caused by these diuretics. When it comes to spironolactone, we should also note side effects like gynecomastia, which is the enlargement of breast tissue in men, as well as impotence and benign prostatic hyperplasia. These are linked to its antiandrogen effects. Moving on to triamterene, a notable concern is acute renal failure and kidney stones. This can happen, especially when combined with other drugs like indomethacin, which can impair kidney function further. To summarize, while potassium-sparing diuretics are useful, they come with a range of potential toxicities that we need to monitor closely, particularly regarding potassium levels and kidney function. Let's continue by discussing the contraindications of potassium-sparing diuretics. First, patients with chronic renal insufficiency are at increased risk of hyperkalemia, so caution is essential in these cases. Additionally, when these diuretics are used together with agents that blunt the renin-angiotensin system, such as beta blockers, ACE inhibitors, or ARBs, the risk of hyperkalemia rises even further. It's also important to consider liver disease. Patients with liver impairment may have difficulty metabolizing drugs like triamterene and spironolactone, which means their doses need to be carefully adjusted to prevent accumulation and toxicity. Another key point involves strong CYP3A4 inhibitors, like erythromycin, fluconazole, diltiazem, or even grapefruit juice. These substances can significantly increase blood levels of eplerenone, potentially leading to adverse effects, but interestingly, they don't have the same impact on spironolactone. Finally, for patients taking spironolactone who also have peptic ulcers, extra caution is advised. It's crucial to weigh the benefits against potential risks in this group. All these points highlight the importance of understanding these contraindications to use potassium-sparing diuretics safely and effectively. Let's talk about aquaretics, specifically osmotic diuretics. These are agents that are filtered by the glomerulus, but importantly, they are not reabsorbed as the filtrate moves through the nephron. Because of this, they cause water to stay in those segments of the nephron and promote a water diuresis. This mechanism makes them particularly useful in situations where we need to reduce intracranial pressure or help quickly remove renal toxins. Some common osmotic diuretics include mannitol, urea, glycerin, and isosorbide. Most of their action occurs in the proximal tubule and the descending limb of Henle's loop. By acting in these areas, they effectively increase the volume of water excreted, which can be critical in certain clinical scenarios. So, understanding how these agents work helps us appreciate their role in managing conditions like edema, increased intracranial pressure, and toxin clearance. Now, moving on to aquaretics and the osmotic diuretics, let's focus on their pharmacokinetics. As you can see here, we categorize the pharmacokinetics into different processes. U for unknown, M for metabolism, R for renal excretion, and B for biliary excretion. For osmotic diuretics, their absorption, distribution, and elimination can vary, but generally, their primary route of elimination is through the kidneys, which is indicated here by R. Understanding these pharmacokinetic pathways is crucial because it helps us determine how these drugs act, how quickly they work, and how they are cleared from the body. This knowledge also guides us in managing possible side effects or toxicity, especially in patients with impaired renal or hepatic function. So keep in mind that while some aspects are well understood, others are still classified as unknown, highlighting areas for further research and careful clinical consideration. Now, let's discuss the clinical applications of aquaretics, particularly osmotic diuretics. One of their main uses is to increase urine volume. This can be especially helpful when traditional diuretics are limited by excessive sodium retention, which can restrict the response. In such cases, osmotic diuretics can effectively promote diuresis. They are also useful in preventing anuria, especially when large pigment loads, like from hemolysis or rhabdomyolysis, are presenting to the kidneys. By maintaining urine output, they help protect renal function in these situations. However, it's important to note that not all patients respond to osmotic diuretics. Some oliguric patients may not show any response at all. That's why, before administering a full dose, a test dose of mannitol is recommended to assess responsiveness. And finally, while these agents can be beneficial, prolonged use is generally not advised, as it can lead to complications. So, in summary, osmotic diuretics are valuable tools in specific scenarios, but they require careful monitoring and appropriate patient selection. Let's continue with aquaretics, specifically osmotic diuretics, and their clinical applications. One of the main uses of osmotic diuretics is to reduce intracranial and intraocular pressure. These agents work by altering Starling forces, which are the pressures governing fluid movement across membranes. By doing so, they cause water to leave cells, effectively reducing intracellular volume. This is particularly useful in situations like neurologic conditions, where swelling increases pressure inside the skull, or before eye surgeries to lower intraocular pressure. Mannitol is the most commonly used osmotic diuretic, and it's administered intravenously to achieve this rapid reduction. So, in essence, osmotic diuretics help manage critical conditions by pulling excess water out of cells, helping to prevent damage from elevated pressure. Let's discuss the toxicity associated with aquaretics and osmotic diuretics. One key concern is extracellular volume expansion, which can complicate conditions like heart failure and may even lead to severe pulmonary edema. This is a critical point because it shows how these drugs, while helpful, can sometimes cause significant fluid overload. Common side effects like headache, nausea, and vomiting are often observed, which can be quite uncomfortable for patients. Additionally, these diuretics can cause dehydration, hyperkalemia, and hypokinatremia, all of which require careful monitoring. Another important aspect is hyponatremia. When using agents like mannitol, especially in patients with severe renal impairment, the drug isn't excreted properly and stays in the bloodstream. This retention leads to osmotic extraction of water from cells, which can dilute sodium levels and cause hyponatremia. So, understanding these toxicity risks highlights the importance of cautious use and close monitoring when administering osmotic diuretics, particularly in vulnerable patient populations. Let's talk about antidiuretic hormone antagonists. As you may recall, antidiuretic hormone, or ADH, is also known as vasopressin. Now, when there's excessive secretion of ADH, as seen in conditions like congestive heart failure and the syndrome of inappropriate ADH secretion, or SIADH, it leads to water retention. This water retention can cause dilutional hyponatremia and other complications, so understanding how to counteract this is important. There are two drugs, lithium and demeclocycline, that non-selectively interfere with ADH. They essentially block the hormone's action, helping to reduce water retention. Now, on a molecular level, vasopressin acts through three known receptors: V1A, V1B, and V2. The V1A receptors are mainly found in blood vessels and the central nervous system, where they influence vascular tone and some CNS functions. The V2 receptors, on the other hand, are specifically expressed in the kidney, playing a key role in regulating water reabsorption. Understanding these receptors helps us appreciate the targeted approach for certain drugs. For instance, V2 receptor antagonists are used to treat conditions like SIADH by blocking water reabsorption in the kidneys. So, in summary, antidiuretic hormone antagonists work by blocking these receptors or interfering with ADH directly, helping to manage water retention in various conditions. This ties into the overall theme of how hormonal regulation impacts fluid balance and how we can pharmacologically intervene when this balance is disrupted. Let's continue by looking at some of the ADH antagonists. Canivaptan, which is only used intravenously, is interesting because it acts on both V1A and V2 receptors. This dual activity can be particularly useful in certain clinical situations. On the other hand, the oral agents like tolvaptan, lixivaptan, and sadavaptan are more selective. They specifically target the V2 receptor. Now, moving on to pharmacokinetics, it's important to note that canivaptan and demeclocycline have a half-life of about 5 to 10 hours, meaning they stay in the system for a moderate amount of time. Tolvaptan, however, has a longer half-life of 12 to 24 hours, which influences how frequently it needs to be administered. Finally, regarding pharmacodynamics, these ADH antagonists work by inhibiting the effects of ADH in the collecting tubule of the kidney. This inhibition prevents the kidney from reabsorbing water in response to ADH, promoting water excretion and helping to correct conditions like hyponatremia. This mechanism is central to how these drugs help manage water balance disorders. Now, let's continue exploring ADH antagonists and their clinical applications. One key condition we see is the syndrome of inappropriate ADH secretion, or SIADH. In cases where water restriction alone isn't effective, medications like demeclocycline or tolvaptan are often used. Demeclocycline requires careful monitoring to keep plasma levels within the appropriate range, ensuring safety and effectiveness. On the other hand, tolvaptan levels don't typically need routine monitoring, which can simplify its use. Additionally, canivaptan is administered intravenously and isn't suitable for long-term outpatient treatment. These options highlight the importance of tailored therapy depending on the patient's situation and the specific pharmacological profile of each drug. Let's continue by looking at some of the clinical applications of ADH antagonists beyond their primary use. One important point is that antidiuretic hormone, or ADH, can be elevated in response to a diminished effective circulating blood volume. This is often seen in conditions like heart failure. In patients with heart failure, water restriction alone is frequently ineffective because these patients tend to have increased thirst and are often on multiple oral medications, which complicates fluid management. That's where intravenous canivaptan comes into play. This drug is particularly useful because it blocks V1A receptors, which leads to a decrease in peripheral vascular resistance. As a result, cardiac output can improve, providing a beneficial effect in these patients. So, understanding these mechanisms helps us see how ADH antagonists can be tailored to specific clinical situations, especially in managing complex cases like heart failure, where fluid balance and vascular resistance are critical. Now, let's continue by discussing the toxicity associated with ADH antagonists. One important toxicity to be aware of is nephrogenic diabetes insipidus. This condition can occur when these drugs cause the kidneys to become resistant to ADH, leading to excessive urination and the risk of severe hypernatremia, which is a dangerous increase in blood sodium levels. If a patient is on lithium for a psychiatric disorder and nephrogenic diabetes insipidus develops, it can often be managed effectively. In such cases, using a thiazide diuretic or amyloid can help reduce the symptoms by promoting a different mechanism of water reabsorption. Another critical toxicity to consider is renal failure. Both lithium and demeclocycline have the potential to cause kidney damage if not carefully monitored. So overall, while these ADH antagonists are valuable, they come with significant risks that require vigilant monitoring and appropriate management to prevent severe complications. Now, let's talk about some additional considerations with ADH antagonists, specifically their toxicity and other side effects. One common issue is dry mouth and thirst, which many patients experience due to the mechanism of these drugs increasing water excretion. Tolvaptan, in particular, may cause hypotension because it promotes water loss without electrolyte loss, leading to a decrease in blood volume and pressure. It's also important to remember that lithium therapy, which is often used in mood disorders, has multiple adverse effects that can be problematic. These side effects can include kidney issues, tremors, and thyroid problems, so monitoring is essential when patients are on lithium. Understanding these potential toxicities and side effects helps us weigh the benefits against the risks when considering ADH antagonists for treatment. It's a key part of ensuring patient safety and effective management. Let's talk about diuretic combinations, specifically the use of loop diuretics. Sometimes, these drugs can become less effective over time, a phenomenon known as refractoriness. To overcome this, we often combine loop diuretics with thiazide diuretics. Now, why does this work? Well, because they act at different sites within the nephron. Thiazides induce mild natriuresis in the proximal tubule, but this effect is usually masked by increased reabsorption in the thick ascending limb, or TAL. When we combine these two types of diuretics, they work together to block sodium reabsorption across all three segments of the nephron, making the overall diuretic effect more potent. However, a common issue we encounter with these combinations is potassium wasting. This can be quite significant, and in some cases, may require potassium supplementation through parenteral administration. It's crucial to carefully monitor fluid and electrolyte status when using these therapies to prevent imbalances. In summary, combining loop and thiazide diuretics can be a very effective strategy, especially when refractory to single agents, but we must always be vigilant about the potential for electrolyte disturbances like hypokalemia. Let's talk about diuretic combinations, specifically potassium-sparing diuretics combined with other diuretics. When patients are on carbonic anhydrase inhibitors, loop diuretics, or thiazides, they often develop hypokalemia, which is a low potassium level in the blood. This is a common concern because potassium is vital for many bodily functions, especially heart and muscle activity. Fortunately, hypokalemia can typically be managed through dietary measures, like restricting sodium chloride intake or by increasing potassium-rich foods or supplements. However, when these strategies aren't enough, adding a potassium-sparing diuretic can be very effective in reducing potassium excretion and balancing levels. But it's important to remember that combining these drugs isn't always safe for everyone. In patients with renal insufficiency or those taking angiotensin antagonists, this combination can lead to dangerously high potassium levels, known as hyperkalemia, which can be life-threatening. So, careful patient selection and monitoring are key when considering these combinations to ensure safety and effectiveness.